We will speak about the urodynamic. Before that, we will discuss the neurological control of the bladder. Actually we have two phases. Storage phase, and this is mainly by hypogastric plexus stimulation. That's the sympathetic. So hypogastric plexus stimulation T10 to L2, resulting in sympathetic relaxation of the trusor muscle and stimulation of urethral sphincters. So adequate compliance of the bladder allows storage of urine at low bladder pressure. This allows filling from the upper tract. The voiding micturition, where the parasympathetic stimulation from the sacral micturition center, that S2S series 4, with pelvic nerve, facilitate the trusor contraction and internal sphincter relaxation. So it is parasympathetic. And the somatic nerve via pudendal nerve relax the external sphincter. So the relaxation of internal sphincter and contraction of the trusor muscle of the bladder, it's via parasympathetic stimulation from sacral micturition center S2, S3, S4. And this allows the lowest possible detrusor pressure, and this is facilitate complete emptying of the bladder. So allowing the lowest possible detrusor pressure able to overcome or outflow resistance during voiding with complete emptying of the bladder. A smooth coordination between the two phases of storage and micturition depend on the intact neural pathway in the central nervous system in cortical, pontine, and sacral micturition centers. So this shall allow social planning and timing, coordination, and amplification, respectively. So we'll start our discussion about the urodynamic in details. So it is a study of micturition and may include uroflowmetry, cystometry. The uroflowmetry evaluates urine flow. Cystometry evaluates bladder filling, so storage. And also include pressure flow study. This evaluates bladder emptying. So pressure flow study, that's evaluate bladder emptying. And the last is electromyography, that's evaluate voluntary urinary sphincter activity. So voluntary urinary sphincter activity is evaluated by electromyography. But the pressure flow study evaluates bladder emptying. Cystometry evaluates bladder filling. Uroflowmetry evaluates urine flow. And also urethral pressure uroflowmetry, this evaluates voluntary urinary sphincters. And cystogram, this image of the bladder during filling and empty phase. And last is residual, known as residual urine or post-void residual. So all this is a component of urodynamic. Urodynamic have this component: uroflowmetry, cystometry, pressure flow studies, electromyography, and urethral pressure profilometry. This is for evaluation of voluntary urinary sphincter, as well as the electromyography, also voluntary urinary sphincter evaluator. Cystogram, image of the bladder during filling and empty, and post-void residual. Urodynamic is most useful when the patient usual voiding symptom occur during the test. Uroflowmetry. The uroflowmetry evaluates bladder emptying by measuring the urinary flow rate, the voided volume, and the voiding duration. So the uroflowmetry evaluates bladder emptying by measuring the urine flow rate and the voiding volume and voiding duration. Three parameters: flow rate, volume, and duration of voiding. Technique: the patient void in flow meter while in normal voiding position. Okay, so the patient void in flow meter while in normal voiding position. Before Euroflow, the bladder should contain at least 150 ml and should not be over distended. That means the patient, it must be not pass urine 2 hours before the procedures. The information can be obtained with uroflowmetry. We have void volume and voiding time, that's the voiding duration, peak urine flow rate, that's the Q max, and mean urine flow rate, that's the voiding equal voiding time, bare voiding volume, bare voiding time. This is the main urine flow rates. So volume per time give us the mean urine flow rate. This is less clinically useful than peak urine flow rate. This calculated value is not accurate if the patient does not contain a continuous flow. Normal flow profile was known as flow versus time, look like bell-shaped curve. So the normal flow or flow versus time is look like bell shape. In this picture is very clear. This is the normal flow. It look like bell shape, and here this is the B. This is a tower shape. This is suggest overactive bladder, as you see, and here this is staccato shape, suggests dysfunctional voiding, and you'll find the bladder of the patient wall, bladder wall is very thick. And the last, this is before the last, here we have this interrupted, suggests underactive bladder. This suggests underactive detrusor with interrupted shape, suggests underactive detrusor with abdominal strain. But the last one here, plateau shape, the plateau shape suggests of static bladder outlet obstruction, either anatomical or functional. The normal peak flow rate in male is 20 to 25, in female is 25 to 30. This is the normal peak flow rate. In male, 20 to 25, in female, adult male, 25 to 30. So it is a little bit high in female. Normogram exists or exit for age-adjusted flow rates. Normal flow can occur with abnormal physiology. Normal flow can occur with abnormal physiology. For example, poor detrusor function compensated by elevated abdominal pressure, weak detrusor function but minimal outlet resistance, or increased outlet resistance but a strong detrusor contraction. Abnormal peak flow rate, if we have a reading or a result of 10 to 15 milliseconds, this is suspected obstruction. If less than 10, this is likely obstruction. Supervoiders achieve a high flow but are not of clinical concern. Obstruction results in low average urine flow rates, low maximum urine flow rate, especially less than 10 ml per second, long flow time, and interrupted flow with subsequent increase in abdominal pressure to restore urine flow, intermittent stream. Again, this is a summary for the procedures. Uroflowmeter done when the patient have a full bladder, and we will ask the patient to retain the urine for 2 hours, drink fluid, extra fluid, so you have plenty of urine before the test, and generally no period preparation such as fasting and sedation is required. The patient urinate in a special urinal or toilet with machine that has a measure device. The patient has to begin urinating after machine has start. Finish the machine, create a report for your health situation. As you see here, this is the Euroflowmeters. The normal is look like bell shape, and this is a maximal flow rate which is about 50. Again, this is the bell shape of normal uroflowmetry. This is the normal flow rates according to the age. This is the minimal voiding volume, for example. The flow rates for each one, male and female, is different accordingly. Residual urine, post-void residual. Post-void residual, evaluate bladder emptying. Post-void residual influenced by the detrusor function and outlet resistance. Post-void residual is measured by catheterization or ultrasound. It can be also determined on the post-void film of a cystogram. High post-void residual more than 50 to 100 cc indicate that the one of the following is present: increased bladder outlet resistance, decreased detrusor function, or both. That's increased bladder outlet resistance and decreased detrusor function. Pressure flow study. Pressure flow study evaluate bladder emptying by measuring the detrusor pressure and the urinary flow rates. The technique, same technique as filling cystometry, the same. We will fill the bladder by normal saline, for example. This is the vesical pressure. This is the detrusor pressure. This is abdominal pressure. And as you see, this is the filling phase, and this is a voiding phase. So in the voiding phase, the pressure start to increase and then decrease. Again, this is the flow rate, the urodynamic in general. As you see, we have rectal catheter and we have urethral catheter or intravesical catheter. This to measure the abdominal pressure, and this to measure the urethral sphincter and also bladder, intravesical, and the detrusor pressure. This is intravesical installation, normal saline through the catheter. This is the flow meter. As you see, this is the pressure. Filling cystometry, cystometrogram, CMD. Filling cystometry evaluate bladder filling. The technique, obtain objective, subjective, and objective measures during filling. The urethral catheter. This catheter is used to fill the bladder with sterile water to measure the intravesical pressure, as you see here. So we will fill the bladder with sterile water. This is the cystometry again, filling the bladder with the water, and water from process the flow from the catheter and the EMG. And this is the component of urodynamic, abdominal, vesical, urethral, urethral pressure, okay, trouser pressure, anemia. Abdominal pressure probe. This probe measures abdominal pressure and is placed into the vagina, the rectum, or abdominal stone. EMG measures voluntary sphincter activity. Objective information obtained from CMG, the trouser pressure. Calculate using the following equation. Trouser pressure equal intravesical pressure minus abdominal pressure. Also, through this CMG, we will check also bladder capacity, bladder compliance, voluntary sphincter function and control, and leak point pressure. Okay, bladder capacity, bladder compliance, voluntary sphincter function and control, and leak point pressure. Bladder compliance, it's equal volume per pressure. Normal compliance is less than 6 centimeter water raised in trouser pressure with filling. This should be noted during the CMG. The volume at first sensation of filling, usually 100 to 200 ml. And the volume at sensation of fullness, usually 350 to 450 ml. Volume at desire to void, usually is 350 to 450. And volume of immediate void, unable to inhibit void any more, occur of voluntary trouser contraction when asked to void. This is a component of the urodynamic. The ability to inhibit a voluntary trouser contraction, presence of the trouser overactivity, and leak of urine during cough and balsava. This study is often combined with pressure flow study to obtain both filling and emptying phase during urodynamic. The leak point pressure, that abdominal leak point pressure, also called valsalva leak point pressure, lower intravesical pressure at which urine leak around the catheter during an increased abdominal pressure, but in the absence of the trouser contraction. If cystocele is present, this test is invalid. Also, is usually started with the bladder half full and then repeat at several higher bladder volumes. Abdominal leak point pressure less than 60 centimeter water imply that the stress urinary incontinence is caused by intrinsic sphincter dysfunction, ISD. If abdominal leak point pressure less than 60. Abdominal leak point pressure more than 100 would imply that stress urinary incontinence is not from ISD. Abdominal leak point pressures of 60 to 100 is intermediate. The trouser leak point pressure, also called bladder leak point pressure. The lowest the trouser pressure at which the urine leak around the filling catheter in the absence of the trouser contraction and in the absence of the increased abdominal pressure. The trouser leak point pressure more than 40 centimeter water places the patient at risk of deterioration of the kidney. A high trouser leak point pressure can cause functional urethral obstruction, which lead to hydronephrosis and renal damage. This is the measurement condition. This is a type of leak point pressure, abdominal or valsalval, the trouser or bladder leak point pressure. This is a pressure measurement intravesical, and this is the trouser pressure. Increase in abdominal pressure in abdominal valsalval pressure, yes, and there is no increase in the trouser contraction in abdominal valsalvals. and this measure is used to determine the presence of ISD, the trouser bladder or trouser bladder leak point pressure measure the trouser pressure, and there is no increase in abdominal pressure, and there is no increase in trouser pressures, the risk of the renal deterioration secondary to this. The reading of urodynamic. As you see here, we have several factors. We have urethral catheter, we have rectal or vaginal catheter. Okay, so the saline distillative pump inflate the bladder pressure transducer, and also rectal pressure transducer is attached through the catheter. Total bladder pressure and intrinsic bladder pressure or vesical, intravesical, rectal pressure, and flow, all this will be studied. We have filling phase, as we mentioned previously. Note the following information about the urodynamic. The compliance in the filling phase, normal compliance is less than 6 centimeter water. Change in the trouser pressure during filling. Capacity in adult normal bladder capacity is 400 to 500 ml. In kids, estimated normal bladder capacity in ml equal age in year plus 2 times 30. First sensation of fullness, this occur at 100 to 200 in normal adult. Presence of the trouser overactive is significant if there are senses cause leakage, cause a pressures increase of more than 15 centimeter water, and is urine leak presence. Okay, so this is about the filling. So we will check the compliance if less than 6 centimeter water, that indicate the normal compliance. Capacity, the normal capacity is 400 to 50, and in kids its capacity is equal 8 plus 2 times 30. First sensation also we check it, that's usually between 100, okay, in 100 to 200 ml in normal adults. And also we check the trouser overactivity. This is significant if the senses cause leakage or cause pressure increase of more than 15 centimeter water. And also we check if there is leak or not. And as you see here, this is leak appeared in all this study. Voiding phase. Note that the following information about the voiding: maximum flow or Qmax. Normal Qmax equals 20 to 25 in male, 25 to 30 the Qmax of female ml per second. Suspected obstruction, that the Qmax is 10 to 15. Probable obstruction, that the Qmax is less than 10 ml per second. The voiding volume is also important. This is the filling phase, and this is the voiding phase. This is the urethral profile example of urethral profile. Maximal urethral pressure is also important, and in this patient is 65 centimeter water. Maximum trouser pressure, BDT max, male normal 40 to 60 centimeter waters, female should be less. Both void residual less than 50, normal. EMG, some question that we can put in our mind, does activity quiet when voiding urodynamic or DSD, sorry, or pseudo DSD. This is does activity quiet when voiding suspected DSD or suspected pseudo DSD. Is bladder contraction sustained adequately? The flow notes of the maximal Qmax or QF, the average flow, and total voiding time, presence of intermittency, and also voiding volume. Video cystogram. Note the following about the video cystogram. The bladder count 2, presence of VUR, estimated both void residual and bladder neck urethra. All this must be checked. The bladder contour, filling defect or trabeculation, diverticular, all this must be checked. Presence of VUR or estimated BVR, does it correlate with measure BVR? Bladder neck. During filling, is bladder neck closed, normal, or opens, typically abnormal? Period transurethral or open prostatectomy for BPH may be create permanently open bladder neck. With this voiding, does the bladder neck open and funnel appropriately? Urethra, there is a stricture. This is a deflection of urodynamic pressure, and this is a vesical pressure, abdominal pressure, detrusor pressure. This pressure tracing patterns based on source of the pressures. Abdominal, this is abdominal pressure here. As you see, increase, and also detrusor increase, and vesical, intravesical increase based on the colon. As you see, increase or decrease, increase and decrease in the abdominal and detrusor. And in abdominal detrusor, increase. This is the deflection of urodynamic pressure tracing. As you see here, this is a diagram of each one. Vesical, abdominal, detrusor. Disease state and their influence on voiding. Location of neurological injury and its importance and its impact on voiding. We have suprapontine, that's including cerebral cortex, causes, if we have a neurological injury in suprapontine area, the patient might have detrusor overactivity with synergy of the bladder and sphincter, normal bladder sensation, usually adequate in. This is a suprapontine. This comes with detrusor overactivity. With synergicity, so the patient has synergic bladders and sphincter. Bones to the spinal cord above S2, upper motor neuron damage. This called detrusor sphincter dyssynergia. So if we have bones to the cortex, to spinal cord above S2, it will lead to detrusor sphincter dyssynergia, spastic paresis of the lower limb. S2 TS4, lower motor neuron damage, causes acontractile detrusor or flaccid detrusor, flaccid striated sphincter, and also flaccid paralysis of the lower limb. Peripheral pelvic nerve cause acontractile detrusor, absence of bladder sensation. This is injury location, urological syndrome, bladder, urethral sphincter, synergicity, lower limb, and BCR. BCR, this is the bulbocavernosal reflex. Sacral cord is the injury in sacral cord, acontractile bladder. The bladder is flaccid and urethral sphincter is flaccid. No synergicity, or not, no comment about it. And also the lower limb is flaccid as well as bladder and urethral sphincters. And no bulbocavernosus absence. The bulbocavernosus reflex is absent is sacral cord. In suprasacral cord, the patient have detrusor sphincter dyssynergia, spastic bladder and spastic urethral sphincter and spastic lower limb, and the bulbocavernosus sphincter dyssynergia, bulbocavernosus sphincter reflex, bulbocavernosus sphincter is present. Suprapontine, that's the patient have neurogenic detrusor overactivity, detrusor hyperreflexia, is the same name. The bladder is spastic, but the urethra is normal. Okay, so this patient have neurogenic detrusor overactivity. The bladder It is spastic, but the urethral sphincter is normal, and it is synergistic. Synergistic does synchronize function of the bladder and urinary sphincter, so it's synergistic, and the rest of the sphincter is normal, and the lower limb is normal, and BCR or bulbocavernosus reflex is present with suprapontine. Suprapontine, when we speak about suprapontine, as I mentioned, suprapontine including the cerebral cortex. The patient have the trouser activity with overactivity with synergy of the bladder and sphincter, normal bladder sensation, usually adequate emptying. When we speak about the bone to the spinal cord above S2, this is known as upper motor neuron cause damage through sphincter dyssynergia. When we speak about the lower motor neuron damage, S2, S3, S4, this is lead to acontractile flaccid bladder, flaccid sphincter, flaccid lower limb. Okay, so and peripheral pelvic nerve causes acontractile detrusor and absent bladder sensation. Disease state and their typical urodynamic finding, multiple sclerosis, detrusor overactivity. Normal pressure hydrocephalus, detrusor overactivity, as well as a patient with multiple sclerosis. Normal pressure hydrocephalus with dementia, the great disturbance, air incontinence from detrusor overactivity, symptom complex of weird, wobbly, and weight. So it's three symptoms: weird, wobbly, and weight. The patient is wet. Stroke, detrusor overactivity without DSD. Parkinson disease, detrusor overactivity is usually absent. DSD is usually absent, but cogwheel of sphincter may result in intermittent DSD. Cauda syndrome, acontractile detrusor. The cauda contain the L2S5 and L2S5 nerve rods. Injury usually generate voiding pattern similar to the sacral spinal cord injury. Spinal shock from suprasacral cord injury. Acontractile detrusor with increased tone in the urethral sphincter and bladder neck. This is causing urinary retention. Spinal shock lasts for 6 to 12 weeks. The bulbocavernosus reflex and deep tendon reflex are absent during spinal shock, but they retain with spinal shock resolve. Tissue cord detrusor underactivity with tissue cord. Thank you. This is the end of the lecture.